Good morning. I'm Akhil from Medicine 3. I'm a third year medical student, and I'd like to thank Medicine 3 for giving me this opportunity to present. The name of the presentation is Corn by the Cob. This is a story of a 52-year-old housewife from Vellore who presented with complaints of cough and fever for 1 week. The cough was initially dry and later progressed to become a scanty mucoid expectorant. There was no association with breathlessness or wheeze. There was no association with the preceding coryza or throat pain. The fever was of high grade and was associated with chills but no rigors. It subsided with paracetamol but recurs in 4 hours. She had a past medical history of a minor coronary artery disease 4 years ago and was diagnosed to have diabetes and hypertension 10 years ago, for which she's on regular follow-up. She was also diagnosed to have hypothyroidism 10 years ago, for which she's on thyroxine. She also had hypertrophic tachymeningitis in 2020, and she was diagnosed in November of 2020, and she presented with the right cavernous sinus syndrome. She received weekly methylprednisolone pulses and MMF, which resulted in complete resolution. However, this recurred in November of 2021, since which she's on 3 monthly rituximab, last dose being on January 2023. The dose which is supposed to happen April 23 was skipped because on doing a B cell enumeration, it showed that there was 0% CD19 cells. There's no significant personal history. On examination, she was tachycardic, tachypneic, and febrile. No other significant general examination finding. On examination of the respiratory system, she had bilateral infrasaccular and infraaxillary crepitation. Her other systems were normal. So a summary of the clinical syndrome, there's a middle-aged woman with an acute febrile illness with a cough which was initially dry and then associated with a mucoid expectorant and bilateral parenchymal lung involvement suggested from the crepitation heard on examination. With a history of immunomodulation with rituximab and a past history of hypertrophic tachymeningitis, an inflammatory disease. And what are your differentials? Sure. So similarly, the differential that we considered was predominantly infectious, the most higher being viral pneumonia, including COVID-19. Also, we considered an atypical pneumonia caused by mycoplasma or chlamydia. And lower down, we considered, because she was an immunocompromised host, a pneumocystis. We also considered non-infectious causes lower down, such as idiopathic interstitial pneumonia or an infective exacerbation of the underlying diffuse parenchymal lung disease. On preliminary examination, her counts were normal. There was no neutrophil shift, and her renal and liver functions were normal. Her ESR and CRP were slightly elevated, and the ECG showed normal as well. When they came, they had done an X-ray from outside, which showed an area of ground glass opacity in the lower right zone. And they'd also done HRCT outside, which confirmed the ground glass opacities in the lower and the subpleural region. So we made a provisional diagnosis of a community-acquired pneumonia, which we are thinking was of a viral or atypical cause, and recognized the score of CURB 65 score of 1. We gave samples for an empirical, we gave samples for an etiological workup, And we started her on empiric treatment of pip-TAS, azithromycin, and oseltamivir. The etiological evaluation came out negative for respiratory viruses, for COVID. Even the blood cultures came out negative, and the sputum culture was also negative. Her temperature continued to be elevated. There was a persistent fever. There was a drop in saturation to 92%, and she had complaints of breathlessness. On doing a repeat X-ray, we saw bilateral interstitial opacities, predominantly in the lower and the middle zone of both lung fields. There's also some area of patchy consolidation in the right lower zone. When you compare to the older X-ray, there was significant worsening of the situation. Because of worsening of the clinical and radiological status on empirical broad-spectrum antibiotics, we upgraded her to meropenem, repeated the WBC counts, which were still normal, and we thought about other differentials such as PCP pneumonia, especially because she's an immunocompromised, tuberculosis, and idiopathic interstitial pneumonias. However, the PCR for PCP came negative, and even the expert for TB came negative. So we decided to repeat the HRCT to characterize the parenchymal involvement better. On the repeat of the HRCT, we noticed the result came out as multiple areas of ground glass opacities and consolidations, with interlobular septal thickening scattered in all the lung lobes, predominantly in the subpleural and the peribronchial areas. On comparison with the previous CT, there's partial or near complete resolution of few opacities with interval development of multiple new opacities, suggestive of organizing pneumonia. So what is organizing pneumonia? It is a diffuse interstitial lung disease defined pathologically by the presence of granulation tissue organized into buds in the distal air spaces. Now, organizing pneumonia can be either primary or secondary. Secondary being due to a known etiology, which can be due to certain drugs, infections, or rheumatological cause. Or it can be primary, which is an unknown etiology, which is known as cryptogenic organizing pneumonia. Crypto in the sense hidden or idiopathic. I'd just like to discuss the pathogenesis of community-acquired pneumonia and also the organizing pneumonia that we thought. So as we know, in community-acquired pneumonia, the pathogen enters the lung and the macrophages engulf the pathogen. These macrophages then go on to recruit inflammatory cells and also activate the cell-mediated immunity and the humoral immunity, which causes inflammation of the lung parenchyma. This causes the lining of the capillary, to become leaky. It increases its permeability, which causes an exudative congestion and follows 4 stages of congestion: red hepatization, gray hepatization, and resolution. When we compare this to organizing pneumonia starts with an acute alveolar epithelial injury, which follows a leakage of plasma protein into the alveolar space, which follows a recruitment of inflammatory cells and a process of organization, which consists of formation of fibrin bands, proliferation of the fibroblasts, and organization of the fibroblasts and the connective tissue matrix. On histopathology, there's excessive proliferation of fibrous tissue within the alveolar sacs and the ducts. This forms organized plugs called Mason bodies. These Mason bodies are usually in the alveoli, in the distal air spaces. However, they can extend up and obstruct the bronchioles, which is why it was initially known as bronchiolitis obliterans organizing pneumonia. On lung biopsy, the characteristic findings are these proliferation of fibrous tissue within the alveoli, forming fibroblastic plugs. I'd just like to discuss some pitfalls of organizing pneumonia. Initial clinical presentation may be indistinguishable from community-acquired pneumonia. Radiological features vary, not always possible to rule out infective etiology radiologically. The opacities are migratory and are seen in our patients require serial cross-sectional imaging, which aren't often done. As secondary organizing pneumonia can be a consequence of certain infections, positive culture results do not necessarily exclude this diagnosis. In our patient, we did the bronchoscopy with the bronchoalveolar lavage to conclusively rule out infectious etiologies, and we did transbronchial lung biopsy to establish the diagnosis of organizing pneumonia. On bronchoalveolar lavage and transbronchial lung biopsy, we saw both fungal and bacterial cultures negative. Expert TB came negative in the TBLB, and cytology was also negative for BAL. On histopathology, however, we saw type 2 pneumocyte hyperplasia and fibroblastic plugs suggestive of organizing pneumonia. There were no granulomas or malignancies seen. So now we went on further to evaluate the secondary causes of organizing pneumonia, to see whether it is actually secondary organizing pneumonia or whether it is primary, which, however, all the results came negative. Thus, we concluded to a final diagnosis of organizing pneumonia, which is cryptogenic, symptomatic with hypoxemia, with a history of hypertrophic pachymeningitis on immunomodulation, diabetes, systemic hypertension, and minor coronary artery disease. So on further course, we stopped the antimicrobials. We gave her prednisolone 40 mg OD, which is a 0.7 milligram per kg per day dose. And we gave her a PCV prophylaxis and supportive care. This resulted in actually a prompt effervescence, normalization of oxygen saturation, and symptomatic improvement of the breathlessness. When we see the temperature chart, since on starting prednisolone, there was an immediate drop in the temperature and a effervescence was seen. Thus, we can have a few learning points that cryptogenic organizing pneumonia is a rare clinical and neurological mimic of community-acquired pneumonia. The persistence of symptoms and lack of response to antibiotics should prompt us to consider the possibility of an organizing pneumonia. And we briefly discussed the pathogenesis of cryptogenic organizing pneumonia versus a community-acquired pneumonia. Thank you.
Thanks, Akhil. Yeah, that was a really well lucid presentation. Is there any questions coming?
Just make a few comments. First thing is this is an immunocompromised patient, so all people thinking infection first, and infection would be the first, second, and third differential before then we consider the organism. Then of course two questions arise in our minds. One is, can rituximab cause an organism pneumonia, and second is whether hypertrophic pachymeningitis can be associated with an organism. The answer to both the question is rituximab alone has not been described to cause organizing pneumonia, but there are people who develop organizing pneumonia as a part of R-CHOP therapy. So whether cyclocostis or rituximab nobody really knows. So if you there in one of those websites called Pneumotalk as a possible cause. Second question is whether hypertrophic meningitis and organizing pneumonia is an association. So this is like sarcoidosis, IgG4 disease can cause both. But idiopathic this and idiopathic that, there are two case reports reported so far. Now is that just an association or there is a causal association? Comment. Yeah, we will follow her up closely to see how she is doing.
So we'll move on to the next presentation by Medicine One, Dr. Shannon.